I'd like to call to order the May 2021 general meeting of the Arlington NAACP at 6:40 p.m. We will open up with a word of prayer. Um, uh, and I will say that just amongst the executive committee of the Arlington NAACP, we have experienced a lot of loss and death and illness among just our small family of executive board members. So we have been going through a lot, and so we'll want you to keep us in your prayers. And so I'm going to toss it to Billy Wilson, who is our second vice president, and he will open us up with prayer tonight.
Thank you, Madam President. Bow, please. Most High God, we come before you once again, thanking you for being God. Thank you for blessing us with the rain, because we know, Father, just like we need sunshine, we need rain. Thank you, Father, for all the many blessings that you give unto us. We come to you also at this time, Father, asking for that peace that surpasses all understanding. As we have many losses within our executive board family, Father, we pray your peace upon our families. We pray that in each situation you will show yourself mighty, and you will let it be known that even after this life, there is something else. And so let us all be prepared for that. So as we on this earth, Father, we pray that you would help us to do the things we need to do that will be pleasing in your sight. In your Son, Jesus Christ's name we pray. Amen.
Thank you, sir. Okay, so we actually have two presentations tonight, so we won't be lengthy with our business meeting. I know that many of you probably saw or heard that the branch had a news conference. I think it was last week. It's an issue that we have been trying to advocate for and deal with the Arlington Independent School District. And it is in regard to hiring, which has long been an issue that we have tried to improve and help the school district improve with regard to diversity and their process, actually. So you may be aware that we got involved with a group of Lamar alumni who were curious about the hiring process for the new head football coach at Lamar. And as we tried to, work with the school district and come to some understanding about what the process was going to look like, the school district was moving forward and talking to us at first about it, but then became silent about it. So we ended up having a news conference to talk about the issue and what has long been our concern about their process and the exclusion of qualified people and qualified people of color for coaching positions and mainly teaching positions. Anything from art teacher to math teacher has always been an issue for us. So not just this head coaching position. And so it continues to be an issue, and AISD kind of refused to continue talking to us about it. And so we held a news conference last week, I think it was May 3rd. If you take a look at our newsletter, you will see some of the news coverage from Channel 8 and the Star Telegram about it. So we're continuing to work on that. And pretty much it's just a good old boy system of hiring coaches and hiring who they want in the position. And we never have asked that they hire an African-American coach. It has been to make transparent the process for doing it. Because what we know for a fact that they have done is pretty much offered the job to someone before it was even posted. We know that for a fact from the horse's mouth. And so that is not the process that we believe is fair and transparent. So we will continue to fight that good fight, and that is just one of the major issues that we've tackled this past month. It is 6:45. I want to also acknowledge that we have had some losses, like I said earlier, amongst our close-knit ranks, and wanted to ask you to lift us up, because we all are volunteers and these people give their all in all to advocacy in Arlington. So please be in prayer for Pastor Kennedy Jones. He lost his nephew, a young nephew, 35 years old, to diabetes. Please be in prayer for Tamiko Sargent, our membership chair. She lost a niece in a car accident. Marvin Sutton, our political action committee co-chair, his mother passed away, and he buried his mother Saturday in Georgia. And Pastor Perry Crenshaw, who is our religious affairs chair, lost his wife suddenly. And our political action chairperson, he is the sole caregiver of his 95-year-old mother. So there probably some more that I've left off. We're all going through stuff, and you included. So just keep us in your prayers. Now we have two presentations tonight. One is going to be brief, and it's from the city of Arlington. We have with us Reginald Cleveland and Naomi Sanchez. Both are MWBE coordinators with the city of Arlington. They're going to talk to us about a pre-bid conference that's coming up for a major project that the city of Arlington, once council approves everything, they will be undertaking. And so we always want to make sure that minority businesses, particularly African-American businesses and Hispanic businesses, have an opportunity to get work on these projects. And so I will toss it over to Reginald or Naomi, or both of you. And we'll.
Okay, whenever you're ready, Madam President.
All right, we're ready. And you want us to put your PowerPoint up at this time?
Yes, ma'am.
Okay. All right. And anybody with questions, feel free to drop them in the chat, and we will ask your questions, and we may take you off of mute so you can ask your questions. But there you go, Mr. Cleveland.
Okay, thank you, Madam President. And good evening to everyone here. I definitely thank President Lisa Simmons for allowing us a brief moment to share this information with regards to our Pierce Birch Water Treatment Plant's improvement project. So next slide. So real quick, one of the biggest things that we want to talk about is with regards to the city's MW program and its impact on this particular project. And for those who may not know, the city has had since December 2013 an MWBE policy. So we were encouraging our prime contractors to utilize certified minority women-owned businesses wherever there was subcontracting opportunities. Now, it was not a formal program where we had goals. It was simply encouragement, good faith effort. And while we were eventually able to get 25%, unfortunately, it was the percentage of participation was not equally spread out to all of our diverse businesses. And so we had a study done, and of course, they concluded that we could do a lot better in terms of being able to reach our goal at the time of 25%, which has been since increased to 30%. And so we are now embarking on an MWE formal program where we will now be setting race conscious goals, and there will be an MWE goal. And so now that means that we are going to require, as part of the contract, that the firm make every effort to utilize certified minority women-owned businesses, and if not, make sure that they show their reasons why, and to determine if their efforts were merit continuing to utilize to accept their bids or not to accept their bids. So next slide. Okay, now the first part is just really just talking about our participation program in general. And this is going to be part of the bid package itself. And as you can see, for this particular project, because it is very unique and it's significantly a once in a lifetime project here at Arlington, it was placed upon our city council to determine what would be the best method to try to make certain that a wide spectrum of our minority women-owned businesses were able to participate on the project. And so of the choices, this was the one that they most felt comfortable in doing. And so in this instance, our council is going to, on next Tuesday, look to approve us on this project doing a race-specific goal. And as you can see here, it would be 4% for African Americans, 7% for Hispanic-owned businesses. There's a 1% for Asian, a 0.6 for Native American, and 7% for Caucasian women. And these numbers are based upon the availability of said companies in the Dallas-Fort Worth Metroplex. So it's not nothing that's just thrown up in the air. These are numbers that have been verified and validated through our consulting firm. We are, of course, it says we are going to encourage them to encourage, but more so than not, it's going to be part of their efforts we're going to be looking for. And the contractors are going to have to make all efforts to try to meet each individual race-specific goal on the project. And in the event that we do have an MWB prime, it will be up to the prime to also make efforts to meet the goal as well. We will allow, and that participation by that prime, regardless of ethnicity, will be counted toward that goal. Next page. And these are the different certifications that we will be accepting for not only this project, but all projects through the city. And so definitely if there are firms out there that you're aware of that has a certification, just know that definitely our doors are open for all opportunities, both construction, design, professional services, as well as goods and services. Next page. And these are the various subcontracting opportunities that are going to be available on the project. So you can see concrete work, demolition, fire protection, landscaping, masonry, excavation, sidewalks, plumbing, miscellaneous concrete, etc. So we feel that there should be plenty of opportunities available where they can utilize our certified minority women-owned businesses for this particular project. Next page. And so based upon the revised schedule, there will be an addendum sent out for this project. They are going to look to have the bids due on Thursday, June the 10th. And so these are the documentations that all of those bidders or proposers or responders are going to have to submit. So they will have to provide a utilization plan, explain to us who are they using, and particularly identifying those that are minority women-owned businesses. In the event if they are not able to meet the goals, and there's going to be each race-specific goal, then they must provide to us a good faith effort in explaining what did they do to try to meet the goals. So the total percentage would be 20%, but again, it is race-specific, so it has to be each ethnicity, not the total, but by each ethnicity. And also, as another way to make certain of their commitments, they also will have to have what's called an intent to perform to verify that between a signed agreement between the prime and each subcontractor, what scope of work they're going to do and the amount that they would be paid on the project. And so for any of those, for those companies who are interested in looking more into the project, we included the website address. And IonWave is our not only our supplier database, but it's also where companies can go to review all of our bid documents, quotes, and anything that in terms of contracting opportunities. And the person that they would need to reach out to specifically with questions about, in this case, not only about the project, but also there's going to be a pre-bid meeting on Thursday, May the 20th. And so if anyone is needing to attend that pre-bid, they're needing to email Ms. Ashley Brown, and that is her email address. Next page. And of course, there will be a site visit. And these are some of the things that will be required of the company, whoever is selected as contractor. They will need to provide monthly reports. They will also, if there's any changes in the scope of the work that could have impact on participation, they'll need to, if they're adding companies or they're having to replace or substitute companies, those things must be approved by us, because one of the things that we're always going to be concerned with is that whereas if there's at times there are going to maybe issues between supervisors and subcontractors that has nothing to do with the project itself. And so we want to make certain that the rationale for removing or replacing a company is justifiable. And so that also includes changes to their utilization plan as well. So a lot of these, we're going to place a responsibility to the primes to do to whoever their commitments are, that they do meet them from beginning all the way to the end. Next page. Of course, there will be a site visit made available, so that will be in person. Next page. And so this is just the just kind of a housekeeping rule that for those site visits, we'll be following that pre-bid conference. This is where they will be meeting in front of it's going to be at the Pierce Birch treatment plant site, so that people have a general idea of what they're looking at. And of course, they must make sure they have personal protection equipment at all times. So that means hard hats. Of course, it means wearing your mask and any goggles or anything in terms of safety for everyone concerned. Next page. And so again, definitely they will be sent out an addendum on that project for a April 20th pre-bid meeting. And definitely for those who are interested, that's what was our first pre-bid meeting. So for anyone who's just wanting to know who were the potential general contractors who have an apparent interest in bidding on the work, definitely again, reach out to Ms. Ashley Brown, or in many cases, you can go to the website itself, get registered, and that information would be readily available. So again, if you know of firms out there that provide those areas of subcontract opportunities, definitely make sure you share it with them, because we want to make certain that during that next pre-bid meeting, which will be happening next week, we want to make certain that we have plenty of firms available for and opportunities to network. Next page. And that's it. And so I'm definitely available for any questions that you have for myself or Naomi.
Okay, there were no
This is
questions in the
Deborah.
chat. Okay, go ahead. I was going to say there were none in the chat. Go ahead, Deborah.
Okay, this is Deborah. I'm on the phone because I don't know how to do it anyway. But anyway, Reginald, this is Deborah Spell calling. Now you've already had a meeting, you said last month, and the next pre-bid meeting is in 9 days. How are the subprimes how are they aware of these meetings? That's my first question. I want to know, how is this being advertised? How are the minority companies how are they participating? And Now you said that there was 4% would be African American, 7% that's going to be Hispanic. Who is your consulting company and how did they determine this?
Okay, that's a lot of questions. So let me try to answer, hopefully
Okay.
answer all of them.
Okay,
As best-
I'll go over them
Oh,
again.
no, that's
if
okay.
you
I think
want.
I recall the questions, but just
Okay,
on the first one, in terms of advertisement, we always highly recommend any companies who are interested in doing business with the city to get registered through Ion Wave. And that's the first thing. But we also make it a point to share the information with our various minority chambers and advocacy groups like the Arlington NAACP so they can disseminate to their members. So if there's anyone that is of interest, that they can themselves, still the point, get registered so that they can look at the information and most importantly, attend a pre-bid so it can provide an opportunity for them to network. Now, in terms of, I'm hoping I answered that question. Now, as far as the numbers, those numbers came, now specifically for the project, all of that came through as part of our final availability and disparity study that was done through Colette Holt and Associates, or CH Advisors. And we do have a copy of our most recent A&D study that was completed last year in September. And so I do believe that the study also includes a table that shows the availability. I believe it shows the availability of MW firms by commodity codes or NAICS codes. So,
and excuse me, and that's for the Arlington area, the DFW area.
yeah, that is for the Dallas-Fort Worth area. Because part of the study looked at the availability, and so it looked at all of our contractors and where they're coming from. And so based upon the majority, which is, they looked at 80% of all of our contracts, many of them came from Dallas County, Tarrant County, Collin County, and I want to say Johnson County. But yes, the numbers are based upon the availability of Dallas, of the major counties where those contractors are coming from.
And that's what Arlington contractors are coming from. Is that
No,
correct?
not Arlington. We're looking at all of our contractors, all of the contractors that the city is doing business with.
That the city of Arlington has done business with.
Yes, that's correct. That is correct.
Okay, so that's very limited. That is very limited.
Not necessarily.
Yes.
Are you talking? Well, okay, I just want to make sure you're not talking about Arlington-based companies. You're just talking about companies that are doing
No,
business.
I'm not talking about Arlington-based company. I'm talking about the number of companies that the city of Arlington has done business with.
Okay, that is
low.
true. That's part of it, but also,
So
I should.
So that number would be very skewed. So we're only going to have 4% representation. So that number is very skewed because Arlington has not done business with but a very low percentage of African American companies, period.
Well,
and that's why.
And Deborah, I do recognize what you're saying, but also part of the study also when they looked at availability, they looked at availability of certified companies in Dallas-Fort Worth as a whole. And so some trades you're going to find African-American companies probably having more people doing like certain jobs, certain trades than others. And that's the same for any other group. So it's not just based upon those companies who are doing business with us, but also looked at the availability of it. But we recognize that the city has done, as far as disparity goes, we haven't done as much business with African-American companies, but we do know that there are plenty of companies in certain areas that we should do more.
Okay, I'm going to jump in here, Deborah, because we're going to have to go to our next presenter. I have two questions. that you probably can answer really quickly. Must the the proposers or responders have water treatment experience? Do they have to have treatment or experience doing water treatment?
Now, for the primes, yes. For the subcontractors, no. And that's one of the reasons why we feel they should do very well with it, on terms of subcontracting opportunities.
Okay. And what about those companies that aren't yet certified? Because I saw your slide.
Yeah, if there are companies that are not yet certified, it's definitely important that they go ahead and at least get the process started. Because the city of Arlington has been being members of the NCTRC, as for example, if a company applies and they are being considered on the project, and as long as the application is in, we can always place that application on priority. So to help speed up the process to make a determination whether or not the company is certifiable or not. It doesn't guarantee it, but it does at least speed up the process.
Okay. And what's the value of this project?
The value of the project is at least $90+ million for 5 years.
This is a huge project.
Absolutely. That's why we emphasize it's a once in a lifetime project. So we don't know when the next time a project of this scope and size will ever come up for the city of Arlington.
Okay. All right. I'm glad you reached out, and once you all send us the flyer, we'll get that posted and tweeted and Instagrammed and all that stuff. And so thank you for coming to us. And is one more question. Is it a JOC or a JOC?
I understand what you're talking about.
Okay.
It is a competitively sealed proposal. So instead of it being, now pricing is important, but we're going to be looking at, it's going to be evaluation criteria, and part of it will include part of the criteria. What does their team makeup look like?
Okay. Got it. Okay, thank you so much. I'm sure we'll have some additional questions, and we're in touch anyway. So you'll hear from.
Yeah, definitely. If for your members that they have general questions about the city's MW program, about this project, definitely share myself or Naomi's email address, and we'll get back to them as soon as possible.
Okay, Naomi,
Again,
if you
thank
could
you
drop
so
that
much.
in the chat. Naomi did drop in the Ironware link and information
Yes,
about
I
it.
put the Ion Wave link, and when you click on that link to the right of it, will say supplier registration, and that's what you will click, and then they can go ahead and register. And I'll go ahead and just drop our email addresses as well.
Yeah, and I love that that platform, and other cities use it too. So I'm a business owner, so I bid on stuff with the city, other cities. So it's an easy, IronWave is an easy platform to navigate. So, and so is your payment process.
Thank you so much.
It is. You can go and track your invoices and see where they are. So it's both those platforms are really good. So if y'all will drop your contact information in the chat, thank you, and we appreciate it.
Thank you very much for having us.
Okay. All right, we're going to transition quickly over to our Health Committee, and Health Committee Chair Lisa Staples Weary is on with our program for the rest of the hour. Madam Chair.
Good afternoon, everyone. As Elisa said, my name is Lisa Staples Weary. I am the Health Chair for the Arlington NAACP. My co-chair is Dr. Barbara Odom Wesley. She will be getting on a little bit late tonight. This month, we have the charge of bringing the program, the general program, and we chose mental health awareness. May is Mental Health Awareness Month, and so we are doing a presentation tonight for mental health awareness. Our speaker tonight is Dr. Kenneth Jones. Dr. Jones, if you can turn your camera on. I'll give a little background and then he will share his screen to start the program. Dr. Kenneth Jones is an experienced healthcare executive who currently serves as administrator for behavioral health at Texas Health Resources. He has a bachelor's degree in social work, 2 masters, a master's in social work and a master's in clinical psychology. And then he has a doctorate in clinical psychology. He's worked in a variety of settings during his career. Dr. Jones is also serves as an adjunct professor at Southwestern Adventist University, where he teaches in the graduate psychology program. He's an active member within his faith community and serves as the church head elder, as well as providing consults for pastoral staff. He has been married 23 years to Jaleesa, and they have raised 2 adult daughters. Dr. Jones is an avid fan of the Dallas Mavericks and the Washington football team. He enjoys reading, camping, and spending time with family and friends. Without further ado, Dr. Jones, thank you so much for your time tonight, and we really appreciate you coming to share this information with us on mental health. Some of the targets he will be looking at speaking about tonight is basically the mental health in the African American community, the impact mental health has all affected us with the pandemic, a call to action for mental health treatment plans for African Americans. Dr. Jones, welcome and thank you.
Thank you so much. I appreciate the invitation to speak to you guys this evening, a topic that I'm very passionate about, and hopefully we can share some information that we can discuss a little bit at the end and see if we can kind of meet the targets that we've set for this evening. I'd like to go ahead and share my screen, and I appreciate your continuing to accept me after understanding that I'm a Washington Redskins fan. That's generous of you. I know I took a chance on that one, but I can feel the love, so I appreciate your continuing to accept me despite my shortcomings. Let me go ahead and share my screen here. All right, can you see the first slide there? Yes, okay. All right, so getting started, I want to talk about some of the impact of mental health within the Black community. Selected a few statistics here that I wanted to highlight. The first one is that ethnic and racial minorities often carry a disproportionately high burden of disability resulting from mental disorders. Now, this probably does not surprise anyone, but I wanted to dig a little bit deeper and look at some of these statistics that kind of make up that overarching statement. You'll note that Blacks make up 12, sometimes 13% of the US population, yet make up 18.7, which is 7.5 million of those who are affected by mental illness. Depression is one of the key mental illness that is certainly a health issue for our country and actually around the world. But looking at depression specifically, the rates are actually lower in Blacks and Hispanics. You see that's 24.6 and 19.6% respectively. However, depression in Blacks and Hispanics is more likely to be persistent. Now, that's interesting, right? Because why would something be actually less prevalent but more persistent when it shows up? So a couple of maybe insights to that. One study says that once depressed, Blacks are more likely than whites to be chronically or persistently depressed, higher severity of symptoms, higher levels of impairment, and not receive treatment, right? So you see kind of our first opportunity there as a community to kind of look at the, what are the barriers, what are the things that kind of come between actually seeking treatment and being able to intervene before we end up with a chronic or persistent level of of depression. Little graph to kind of illustrate this a little bit. On the left, you see any mental illness in the past year among adults. This is by race and ethnicity, 2008 to 2012. You can see there as you compare the Black or African Americans at 16.8. American Indian and Alaska Native is at 22.7. Two or more races or biracial is at 24.9. You can see Hispanic and Asian there at 15 and 13 respectively. So when we pivot over to people with any mental illness and the percent receiving services, and this is a study from 2015. So to receiving services, 48% Caucasian, 31% Black and Hispanic, 22% Asian, and 46% identified as biracial. Any surprises there? So if we look at utilization and access, right, this is a pretty big topic within the research, and quite a few groups have taken aim at trying to impact this particular area of service delivery. In 2018, 69% of Black adults with mental illness and 42% of Black adults with serious mental illness received no treatment. It's a pretty big number, So when we look at that as a baseline, and then we add this thing we call a pandemic, present tense, you can kind of guess what's likely to happen. We're going to exacerbate a problem that is already critical. And so some of the things we've seen is straining the access routes for the most vulnerable and the marginalized in our society. So you've got familiar clinics that individuals had established relationships with. They went remote, went online, some of them closed, right? So it had quite a bit of an impact on those resources. It'd be nice to believe that going online or going virtual would increase access to underserved communities, right? Theoretically, it's a beautiful idea. In practice, it did not happen that way, right? And so the access actually decreased. Case managers reduced or stopped making in-person visits. So this is a big part of community-based mental health treatment, is having a network of case managers who actually check in home with individuals, encourage them to attend their visits, and try to intervene before the condition has gotten to an acute level that requires hospitalization. So those individuals stopped making those house calls. And then increasing ranks of the uninsured. Certainly we saw impact across the board as far as the jobless rates, and certainly the African American community was hit very hard in that respect as well. And overall, you've got delays in seeking treatment. Now, this is not necessarily completely specific to our community. However, when you have stay-at-home orders, right? And people are going, you can't go out. You start thinking about what type of contact is absolutely necessary to maintain my health and well-being. And we saw decreases in critical services such as surgeries and individuals who were experiencing cardiac issues that would automatically have gone into the emergency room, kind of tended to put those off. And so there's been concerns across healthcare in terms of the delays in seeking treatment. But as you can imagine, mental health certainly did not become a priority for many individuals. Now, I'm an administrator at an inpatient psychiatric facility, Texas Health Arlington Memorial. And I remember kind of looking at kind of what was happening and wondering what's going to happen to the census, what's going to happen to the number of consumers at the front door. And it got really quiet for a couple months, March, April, May of last year. And we're sitting here going like, we know they're out there. right? And when you have this kind of an unprecedented event taking place, those along the fringes get pushed even further. And so the concern was, when is the dam going to break? And we started seeing that towards July and August. Lots of anxiety, and individuals who you could tell, had they sought treatment earlier, we probably would have been able to intervene earlier. So delays in seeking treatment impacted our community quite a bit, given what was taking place in our country and around the world. So I'm going to shift quickly to beliefs and attitudes towards mental health treatment. Research has shown that a highly stigmatizing perspective within our community results in low treatment seeking. So what do we mean by that? Well, in terms of the way we talk about crazy, right? The way we talk about he's a little off, she's a little off. The way we talk about mental illness, it's still very stigmatizing in many parts of our community. And that results in individuals not really wanting to share when they choose to seek treatment, or perhaps just deciding, maybe I'll just pray it out, maybe I just need to talk to somebody, but I'm not going to actually seek formal treatment. Amongst older African Americans, depression tends to be viewed as a sign of weakness, and this is still an attitude that is pervasive today and has been pretty stable over research over the last 10 to 15 years. African Americans are more likely than Caucasians to believe mental health professionals can help with mental illness. However, this does not correlate to actually using said services, right? So our beliefs have actually advanced in this area. So I was excited to see this part of it. However, it is not impacting behavior. Think about that for a second. I believe it's good. I believe it can provide relief. Yeah, I'm not doing it, right? So not too many issues are faced with that type of a cognitive sequence. Typically, if it will provide relief, we're all about it. Just anybody wants to seek relief. So the factors that are restraining that more intuitive approach have to be pretty well entrenched. Touch base on that a little bit more on our next slide. African Americans are more likely to believe that mental health problems could improve on their own. So that has become and been maintained as a coping strategy, right? Spiritually, we have the phrase that this too shall pass. And that has been a source of hope and encouragement for our community going as far back as you want to go. However, it is not universally applicable to every situation, right? This too may be exacerbated, might be more appropriate for mental health that is not treated. And so that becomes a coping strategy, or has become a coping strategy that tends to lend to what we talked about at the beginning, and that is the severity and the chronicity of mental illness is higher within our community. And I mentioned reinforcement of negative or stigmatizing views on mental illness. Moving quickly, improving access. What are some things that we can do? One recommendation is to increase Black representation within the provider network of mental health treatment, right? There's quite a bit of research that basically says when Blacks are able to see individuals who look like them, they're more likely to stick with treatment, and they're more likely to actually show significant benefit. Now, that doesn't mean that you cannot receive benefit going to see a white provider or a provider of another race. However, there are things that are unique to our community. There are connectors. There are common shared factors and experiences that actually are really important for many of us when it comes to sitting down and bearing my soul to somebody in a way that I don't have to worry about how they are perceiving the things that I am saying, right? I don't have to vet them in terms of the ally or the semi-ally or the completely asleep. So, so that's something that is to be encouraged. Now, I will say here in Texas, there are quite a few African-American providers. If you search whether it's an insurance website or Psychology Today, it's not as hard to find African-American providers as it was 10 years ago. So that's a positive. But there's connection problems, right? We have not connected well enough with our providers to where we can actually have a go-to. So that's another recommendation I made, is that we familiarize ourselves with our local community resources. Where are the hospitals around that if somebody is suicidal and having thoughts of ending their life or having a plan, where would I go? Who would I call, right? Could I do something more than give them 1-800-SUICIDE? What might I do in that moment of crisis? Where could I drive them to, right? So familiarizing yourself with those resources, and then identifying a go-to professional and as a consult in case you see someone in need. I receive calls all the time from pastors, from other contacts in the community, and they just want to run something by me or bounce something off me. Hey, I don't know what to make of this, but let me just tell you the situation. I don't need any names, just what's the situation? What do you think? And there's been times when it's been like, okay, well, that's, appreciate you bringing that. Probably good to connect them with a counselor. And there's been times I said, bring them in tonight, right? Or let's call law enforcement, but this is critical. This is a life on the line. We need to act quickly. So being able to be a bridge, because we all hear about individuals who are struggling, right? But knowing how to connect them and in what situations there's a heightened urgency to get them to a professional is important. And I'll just add there, there tends to be resistance when it comes to, if I've shared that I'm struggling, do I really need to go see someone tonight? Or maybe I'm just having a bad week. Maybe I'm having a bad day. It is not normal for bad days to result in the desire to shoot oneself in the head. That's not the normal result of a bad day, a bad week, or a bad month. So when the brain flips over to beginning to have persistent thoughts of wanting to end its own existence, that's clinical, right? And those are things we want to act with urgency and with persistence. There are times to be pushy, and this is oftentimes one of those windows in which saying I'll pray for you and give you a call in the morning might not be the best course of action. I'm coming over. I'll be there in 10 minutes. Let's go. Become part of the conversation. There are lots of opportunities within the community to attend free community events, but becoming part of the conversation, I think, goes a little bit deeper than that. And that's being aware of when stigmatizing conversation is taking place in your hearing and standing up for the cause in that moment, right? We all love to laugh. It's fun to make jokes, but when there's jokes that maintain detrimental, I lost my word, detrimental stigmas within our community, then someone needs to speak up, right? Someone needs to speak into that window and go, that's actually something that people struggle with. And so I don't think we should be laughing at that person. I don't think we should be making fun of that person. I think maybe someone should reach out and talk to them, or let me reach out and talk to them. A mental health first aid training is a free resource that is available across the nation. There's quite a few areas that offer that in Texas. Texas Health Resources offers that as well. It's a fantastic class to help people become more comfortable in talking about mental illness and in being a connector, but being able to actually render mental health first aid to somebody who is in crisis. So that's an incredible resource. If your community organization or your church hasn't engaged in providing an opportunity for people to come and sign up for mental health first aid, consider doing that. Consider being the one to speak up and go like, hey, this is a program that I think we might be able to bring to our church, and let's see if we can get this going. I listed a link here that has quite a few resources for mental health and suicide prevention, but becoming an advocate for suicide prevention in your community. In most groups I speak to, if I ask, do you know personally of someone who has committed suicide? And most of the time, 20%, 25% of the hands in the room go up, sometimes more, right? And suicide leaves such a hole in so many individuals. And it becomes a lifelong thing that people carry. I was 16 when my favorite uncle shot himself in the head. He'd come back from the military, and things have been different ever since that, and struggled with jobs, started hearing voices. My family didn't know what to do. And so some of the things that you would expect, lots of pray about it was happening, and lots of conversations about he can't be on them drugs, right? We can't, those drugs are what's causing the problem. And so as a family, we pulled against the things that he actually needed subtly, but we weren't supportive of the treatment that he, in essence, needed. And so one night, after his job as a security guard, he took his gun and ended his life. And my family's never been the same. My mom's never been the same. As her younger brother. And so I know firsthand, I know many of you know firsthand the impact that has and the questions that it leaves with the loved ones behind of what could I have done differently, right? We would like to end these kind of funerals in our community. Partnering with clergy to raise awareness. I'll go through this quickly. One study interviewed 121 African-American pastors regarding their pastoral work. They actually reported an average of 6 hours of a week spent in counseling, much of it dealing with individuals with serious mental illness concerns. Now, I've never been to seminary, but in talking with those who have been, this is not a minor that is offered in many seminaries, right? And talking to clergy, they know they're over their heads when it comes to certain situations, and so they're oftentimes very willing to partner with a professional in the community so they can have someone to bounce some things off of. Like, when is this something that is of a spiritual nature that can be addressed at that level? And when has it become something that's clinical that either needs to be handled in a partnership or referred to a mental health professional? Now, look, the history of the relationship between churches and psychology has been strained, right? And that's not just African Americans, but psychology at its onset was extremely caustic towards religion. And from Freud on down, the idea of individuals who believed in God was a subject of derision, right? Religion is the opiate of the masses. It's a crutch for weak people, on and on. There's been a lot of progress since then, but that distrust still exists, and you hear that when you talk to pastors, because they're concerned that the person I send my parishioner to might try to change their beliefs on a spiritual level, or might not share our faith and might end up doing more harm than good. So we want to bridge those concerns. There are many of us in this field who are members of a faith community and do have an understanding of that relationship. But in general, the field has moved much further towards an understanding that that religion is actually connected with many factors of well-being and mental wellness. And so that argument is completely flipped to where people are looking and going, spirituality is actually important. It's actually a fundamental part of who we are, and to ignore that is actually the part that creates, more, creates mental stressors and pulls from our mental health. Studies have consistently shown that Blacks will seek out pastoral counselors before they will seek out a licensed professional. Again, not surprising, and your pastors will tell you, yeah, that they're coming to me first. And so they play an important role in mental health in our community. And so it's important to establish them as allies, and to be able to work together. I'll tell you one thing I've experienced personally is something as simple as a pastor mentioning depression in a sermon, or mentioning, my wife and I actually went to marital counseling for a while, and it really helped. And the phone starts ringing. Immediately, the phone starts ringing. All it takes is really just saying something positive, or something that is that gives permission to actually seek counseling, and individuals will actually begin reaching out just like that. We have this thing where we kind of have set up this bifurcation between God or pills, God or antidepressants, right? I just take it to God versus taking it to man. And we only do this with mental health, right? Child has a hairline fracture in their leg. You pray on the way to the emergency room. It's not either or, right? And I could go on and on. Any medical example you want. We pray on the way to the treatment that God has led us to. We don't say it's either or. And so we want to speak into those spaces when we hear things like that, to hopefully speak a word in due season, to the extent that people will begin thinking differently about that. God has worked through medicine to provide relief in ways that we did not have relief 5 years ago, 10 years ago, 20 years ago. And so in this respect, I think it's more of a God is in and through rather than opposing mental health treatment. So a quick call to action. I said post-pandemic. I'm not sure that's an accurate statement, but let's keep hope alive on that one. Hopefully we're getting closer to that than we were last week, right? So I mentioned intentional use of your social sphere of influence. Check-ins. We're coming out of isolation, right? And there are populations who were isolated before the pandemic and are so much more so now. I look at our geriatric population, right? Who many of them were lonely before. And you think about what it's like for them now, their kids, their loved ones, out of fear, have said, I can't go see mom. I can't go see dad right now. I'm sure many of you have had to make that decision, right? Like, I haven't hugged my mom in how many months now, right? But I'm not going to be the one to take something to her that results in her getting COVID. So check-ins are important. Check in with individuals who may otherwise seem to be okay. Hey, how are you doing? How's it going? How are you feeling about things? Don't assume that people are all right, but adopt a stance of checking in with individuals. After a crisis takes place, whether it's a short-term crisis or something that people have gone through together, whether it's a hostage situation or whatever, it's really natural for people to go, hey, you good? You okay? Are you all right? It's a natural thing to just go around the circle because we went through something together, right? When we go through something together and we emerge on the other side of that, it's normal to look around and go, are you good? So I'm encouraging you to look around and say, are you good? Check in with those within your sphere of influence. Be aware of what I call the coded language of distress, right? We talk about things a little bit differently. My nerves is shot, right? And oftentimes, as I'm in session with someone and I hear that, I have to ask, what does that mean? I have to ask a lot of questions to actually get down to what that actually means. And oftentimes, it's actually either a psychotic break or something that is very much clinical, but it's classified as nerves or an anxiety disorder. Overwhelmed is a word that we use quite a bit in the Black community in terms of describing this sense of I've gotten to a point where it's more than I can manage. And sometimes it's just that, and sometimes it's more, right? So we want to be aware of that language. Going through, so-and-so is going through. You're just going through. So pray for them, pray them through, right? I don't know what going through means. Going through what? To what depth? To what extent? How are they doing while they're going through? I don't know those things. We need to ask the additional question, not just assume going through is some sort of spiritual tunnel where if you just give it time, you'll emerge on the other side. Maybe, but maybe not. And needing time alone, just need to be alone. That's not necessarily seen as a red flag, but when that seems to be a consistent state of wanting to be alone, it's important to kind of reach out and ask some questions. And lastly, be intrusive. Be intrusive. What does that mean? It actually means just what it says, right? It's important to be nosy in these type of situations, because one of the things that depression has its own language, and it will tell you that nobody cares. And when someone listens just a little bit, ask how you're doing, as soon as you start saying how you're doing, you see them kind of like turn it off. It validates what depression is already telling them, that I'm actually alone in the middle of a crowd of people, right? People don't want to hear my pain, so I'm just going to go ahead and keep it to myself. Or I don't want to be around others because I'm going to bring everybody down, right? So these beliefs, we don't want to be part of supporting these beliefs that individuals are already struggling with. I can't tell you the number of times that I hear people talk about, no one notices that something's different with me. No one notices. They're in my house. They see me every day. I feel like they just don't see me anymore, right? And you talk to the family, it's like, yeah, I noticed something's a little bit different, but I just want to give them their space, right? And so I'm challenging you to be intrusive. Be intrusive. When you approach somebody in love, it's not disrespectful. Oftentimes it's exactly what they need to counteract the belief that I don't matter, that other people will be better off if I weren't here, right? And so we want to be lovingly intrusive in these situations, and make sure that that individual knows that we care enough to stop and push until something happens that gets them out of that situation, right? You should go take a walk, get out of the house. You just sit around in the house all day. How likely is that to actually result in someone getting up off the couch, right? Let's go take a walk. Now that'll work sometimes. Other times you may have to grab them by the elbow and say, let's go take a walk. Whatever you have to do, right? But actually be part of proactively getting that person to the treatment they need, but on a basic level, letting them know that you care and that you see them, right? That they matter. So kind of went through that really quickly, but wanted to kind of open up for questions, thoughts, comments on of any of what was shared. It's a lot to cover in a short window, but what questions might you guys have, or just feedback on any of what you heard this evening?
Dr. Jones, that was an excellent presentation. Lots of information. We can talk about it all night because people have been going through a lot this last year. Me personally, I'm a healthcare provider, and as a registered nurse, I've had the COVID fatigue, the insomnia. Everything, all of it. So I do like the mental health versus mental wellness aspect of dealing with the incidents in the last year this pandemic has brought upon us. One of the things I know that haven't been a lot of research on, or it hasn't been talked about as much as the children and young adults, especially the children being homeschooled
Right.
versus the college age children who had planned to go away to college and now are at home doing college online, the social aspect of that. And I know that all of that has increased a lot of suicide ideation,
Right.
and actual suicide incidents itself.
Right.
And I know that they've been overwhelmed. A lot of parents have been overwhelmed. Some have been in denial and not really knowing where to get the treatment that they need for their children.
Right.
I know at one time that Texas Health Resources were going to open some Medicaid beds. Did they ever open those mental health Medicaid beds?
So, so we don't actually divide in between Medicaid beds, unfunded beds, funded beds. As a nonprofit, that's immaterial to us. So anyone who needs help, who's experienced a mental health crisis, if we have a bed available, we will treat them.
Okay.
It's a shame that we've ever had to go through as a behavioral health community the whole concept of Medicaid beds. It's a terrible discriminatory
Right.
chapter that I hope that we move away from. But I can tell you, as for Texas Health, we don't even ask about insurance or ability to pay when we do an assessment. Our assessments are free to the community. You can walk in anytime and receive that assessment. And once we establish what the recommendation is or how severe things are, if it's inpatient, and that's what we need to keep somebody safe, we admit first, and we'll talk about finances if that's available later. But that's never going to be a barrier in terms of someone receiving crisis treatment at Texas Health.
Okay. Didn't want to have any questions that they wanted to ask?
Yes, we have a couple questions.
Okay, go ahead, Billy.
Okay, I'm going to kind of put two of these together. One question says, what is your confidence, your current level of confidence for law enforcement's ability to safely and effectively facilitate mental health calls? And what suggests, if you don't have a lot of confidence in it, what suggestions do you have for what people can do when they have people who are in crisis?
Ooh. It's not high, to answer the first part of your question. It's a great question. It's not high. And I don't know that there's a reason that it should be high by anyone's estimation, right? Again, there's so many broader things about this, but if we just boil down to the basic training aspect of this, right? Implicit bias, all that stuff aside, they are not trained to deal with mental health crises, right? This is not part of their training. And so I've spoken at police academies before. I wish they'd invite me more often, but that's just not an emphasis of them and for them. And frankly, I think there's some mutual, feelings on that from the law enforcement side. They don't want to deal with these situations either. And so when we talk about movements such as defund the police, which is if you were marketing, that's a terrible way to name what we're actually trying to accomplish.
Amen.
Many of them are actually in favor of having social workers come out on these calls, right? So my hope is that movement actually continues to take root in enough key cities where it actually makes a difference, because we should not have to fear calling for help and worrying that somebody's going to end up dead. And that's not something that I can say confidently is where we are, unfortunately, at this point. So, yes.
In our discussions with police, and it is more of a community policing and public safety issue, right, as opposed to a law enforcement issue.
Right, right.
And so we talked about, okay, can we get another number besides 911 or something like that? And somebody just asked, are you aware of any Black psychologists? Are y'all talking about this situation and professionally among Black psychiatrists? I mean, I'm sorry, I call it psychiatrists, but yeah.
Yes, it's definitely a hot topic. I think we're in one of those windows where change can happen, right? We've had enough disruption to the status quo where this is kind of that window where if you're going to make change, it needs to happen now because there's receptivity to maybe we should do something different. And so I'm hoping that these conversations connect. You know, law enforcement is a difficult culture to crack, right? As a group, but as individuals, I've got plenty of people that I respect highly in law enforcement, and my conversation with them, they would actually welcome some assistance in these situations. They know they don't assess these well, but we have a system that is just, it's backwards. You know, someone can walk in here suicidal with a plan. I assess them. They go, you know what? I don't think I want this. I'm going to go on home. And I have to call law enforcement to come out and assess them to determine whether to apt them as an involuntary into the unit. So if they come assess them, and oftentimes they won't even talk to me. They'll just, I want to talk to the patient. Patient said, well, yeah, I'm not suicidal. And he said, well, he didn't say it to me, so I can't take away his rights. And they walk out the front door and I document. That's all I can do, right? That's a crazed system. It makes no sense that somebody with 18 months of education in a different field can come in and make an assessment over somebody who is trained and licensed in the field and say, well, he didn't say it to me, so I can't do anything, right? And that's a Tarrant County thing. There's other counties that do that a little bit better, but it's just an example of going, there's so much work that we can do, and we're ready. We'd be happy to step into some of these spaces. I know plenty of social workers that are plenty courageous. They'd be happy to respond to some of these calls. We're not scared of mentally ill people. We're not, right? The police are oftentimes. And so being trained to assess things like this, you know, it really makes sense for us to form some sort of partnership where we can actually respond to the needs of the community in a safe and effective manner.
You made a good point. They're not capable of assessing that. I personally had at work a person that I had to call 911 on for transport to Millwood.
Right.
But when the police got there, they wanted to take him to jail. And I was like, no, he doesn't need to go to jail.
Right.
The things that he has said to me, he needs to be in a facility. And as a result, he ended up being there for a while, ended up on medication.
Right.
Since then has relapsed, but I make the point that they wanted to take him to jail.
Right.
And that's not where he needed to be.
And you think about the level of force that they look to use on the same people that I have here on the other side of these walls with behavioral issues and whatever. And I have techs, you know, this tall, helping manage those individuals with no weapons. We don't hurt them, right? But we're able to provide, it's called treatment. We're able to provide treatment because these are not threats. These are individuals who are experiencing mental health crisis. Right. And as professionals, there's a way to provide treatment. But even when law enforcement comes in to serve, you know, a warrant or whatever they come in for, if they're called in for some reason, it's a struggle sometimes for us to just get them to leave their weapon in a lockbox at the front. I don't separate from my weapon. Well, we prefer you not take that onto a locked unit. And they have a right to bring that on, but it just kind of shows you like you feel you have to take a weapon onto a unit where none of us have anything.
No threat.
Not worried about it, right? But you are. So there's a lot of work to be done, and I'm not trying to talk ill of law enforcement, but they're set up. They're set up to fail in terms of being effective in a public safety capacity with mentally ill members of the community.
So what suggestion do you have somebody if they have a loved one in crisis and they don't feel comfortable calling 911, what would you suggest?
Yeah, it's a very serious question, and it's an important question. And so I'm going to kind of go back to my statement about connecting with a member of the mental health community, with a provider, within the community, somebody that you can call first, right? I think if we could begin to do that, we could save some lives. We could save some lives. I'd be happy to get up at 2 o'clock in the morning if you tell me there's a situation and you don't want to have to call the police. I'm getting dressed. Like, I'd be happy to intervene, so somebody doesn't lose a child. So making those connections, and it's not just Black providers, just make connection with a provider, because we're all passionate about the mentally ill being treated with the proper respect that they need to.
Yeah, and this kind of leads into my question, because I'm an educator and I worked over on the East Side at a low-income school, and we deal with a lot of trauma. And even when we just had our discussion with the school district, we were trying to get them to understand that each school needs social workers,
Right.
licensed social workers.
Right.
So based on that, what is your confidence about how the schools are handling their mental issues and the trauma that those kids are coming with? And what suggestions would you have for helping to deal with that? Because once again, if we get them early enough, they can develop those habits
Right.
that when they're adults, they'll feel comfortable dealing with it. So how do you feel about that space?
So this is a legislative issue in the state of Texas, right? And while I'm all about getting involved in the micro at a micro level, this is a macro issue. The funding that we provide for mental illness in this state is almost criminal, right? And it trickles across multiple domains. So whereas schools at one point were very open to hiring licensed social workers, there's not funding for that the way it used to be. And so now it's called a school counselor. But if you talk to any school counselor, they're not doing counseling a lot of the time, right? They're doing testing and scheduling and working, in conjunction with the special ed department. There are there's big classrooms, there's certain classrooms that are designated for that. But in terms of having a social worker for each school, that's something that we have to push for at an Austin level, at a legislative level.
What they've done is they've hired people called social support people, and
Right.
kids can go to them and talk to them. And the ones that we had at our school are good, and they are the type of people that a kid could call at 2 o'clock in the morning if they're in crisis. But
Right.
they're not social workers, and they're not. They don't really know how to handle the situation.
Right. Yeah. And frankly, if you're talking about Fort Worth ISD, they've actually been relatively advanced, believe it or not, than from other districts in terms of having counseling services and having social workers. Now, again, I'm not sure what's happened in the last 5-7 years, but I remember at some point there was quite a few openings for social workers. So it's an issue. It's a funding issue, and it's an advocacy issue, because the residential treatment facilities that used to be kind of where these kids would end up, there's not one in North Texas for mentally ill adolescents. There's not. So Austin,
Earl,
there's one close to Killeen. There's some in Houston, San Antonio, but there's not one even in North Texas. And so where are these individuals? Where are these kids going? They're mainstreamed, right? God bless our teachers, because these are kids that used to be in residential treatment in areas where they would actually receive treatment in a safe and oftentimes confined environment. And now that confined environment is a classroom with, 16 other kids. So
30.
A lot of work to be done in education when it comes to meeting the needs of our kids who are struggling with mental disorders.
Okay, we had another question about funding for someone who is mentally ill and needs medication and does not have insurance.
Right. So, in terms of medication, one of the best resources in this area is the JPS clinic. They have a walk-in clinic where you can walk in and see a prescriber, a psychiatrist, or a mid-level, and actually receive medication or a prescription for medication, there on the spot. So that's probably the best resource in the area. There are churches that have clinics that also have providers who donated their time and help with that. There are medications that are on we call the Walmart $4 list, right? And so there's a lot of medications that are actually available for $4, and there's ones for several different diagnoses, mental health that are available. And so when doctors see someone who does not have perhaps the means, they will intentionally choose something off of that list so the person can actually afford it and continue to receive that. So there's not as many services as we like, but certainly there are some that are available when it comes to helping individuals receive the medication that they need. Some of these clinics also offer it's called long-acting injectables, and those are medications that actually work for a prolonged period of time. So for people who are treatment resistant, they have trouble taking their medication every day. There's people who aren't mentally ill who have trouble taking their medication every day, but for individuals who are on it for 2 days and off it and back in the hospital and back out and on it and off it, oftentimes they're good candidates for a long-acting injectable where they only have to receive it once a month, a shot once a month, to help stabilize their mental health. So, and sometimes it's longer than a month. So those are kind of breakthroughs in the field that we want to help connect people to for our bipolar and our schizophrenic members of the community.
Okay.
We have a raised hand. Elisa, you can go ahead. Dr. Jones, could you put your contact information in the chat for us, please?
Sure, absolutely.
Okay, thank you, Dr. Jones. This is really good information, and we are recording it, so we will post it on our Facebook and social media pages. So I have a question to see if you're able to give some specific step-by-step instructions. So for people, and Mr. Wilson asked part of this question earlier, but I want some specifics if you feel comfortable giving them. For people that feel like they need to call the police for help, what instructions, what guidance do you have for a family member and somebody's, having a break or whatever, and they feel like they cannot handle this in the moment,
Right.
and they call police? They feel like, what should they expect? What should they tell the call taker? How should they respond when the units arrive? Like, don't run out the house. I mean, stay on the phone with the call taker. So what steps do you advise for them to take? Because you've seen it over and over again.
Sure.
We saw it in Lancaster. Was that yesterday or today? These shootings happen so much, I can't even keep up.
Yeah.
So what specific steps?
So I guess let me start with making sure that the police are the appropriate and last resort to respond to a mental health crisis. And I'm just being candid. If there's a way to manage that person, or if they're not in immediate harm, somebody who's out in a public place and won't come with you or won't whatever, but they're not presenting an immediate harm to themselves or others, I would try other means. I would use, if you're able to get the person in the car and say, hey, let's go get you some help, bring them to the emergency room, bring them to any one of the facilities around. MHMR has crisis clinicians that can respond to a crisis on the spot, and so that's another resource. And oftentimes police will actually work with them. So we're starting to see some of that collaboration take place. But calling MHMR crisis line and having them respond to that is another option that I would look at ahead of time. But I would really stop and think: is this an emergency? Is this an emergency? Someone acting strange is not necessarily an emergency. I want to, it's got to be imminent risk or harm to themselves or others. Otherwise, look at less, look at other means of intervening.
Yeah. And I probably shouldn't have used the Lancaster incident because that was, the family member that called said that he was shooting. But there are countless other examples of where family members just they don't know what to do, and they're not weapons involved. So
when we make the call, and I'm going to kind of answer what you said, that when you make the call, give information that would help law enforcement feel more comfortable in responding to the call. This person is experiencing X. Be very specific about what you see, what you hear, what they're doing. They are unarmed. They're not aggressive, but I'm concerned that they're experiencing a crisis. But again, there are no weapons present. I will be outside when you arrive. I'm wearing a blue t-shirt. Again, my name is so-and-so. I will be standing out front when you arrive, right? But be very clear. I mean, again, you want to help them feel as comfortable as possible in responding to the call, right?
right.
Want to sound as calm as you can, right, on the call, because some of that stuff translates to, if you're hyped up, then they're going in, there's a high likelihood that they're going to come in hot. So make sure that as you're explaining it, that you're explaining it fully. Give them a picture, a word picture of what they would expect to see when they arrive, and give them a contact person to speak with upon arrival, right? I believe it's important to try and manage the scene in terms of bystanders and neighbors that would come out and that sort of thing. But whatever you can do to control that scene to where you don't have antagonistic individuals who are saying this and that to the police, or people who are barking at them unnecessarily. But try to keep that scene, to the extent you can, keep that scene as calm and respectful as possible, so we don't heighten a situation that does not need to be heightened. So if there's people who are out there who are unhelpful to the situation, strongly advise that they leave or take a step back or whatever. But try to keep the situation as calm as possible, so that it increases the ability for them to deal with that subject in an appropriate way.
Can you talk about mental health warrant? What is that?
Sure. So a mental health warrant, and there's so much, we use so many acronyms for these, it really does become confusing to the public. But a mental health warrant is when the law enforcement deems that an individual is a danger to themselves or others, and is not willing to voluntarily seek treatment. Therefore, they will write a warrant for them to be assessed and possibly treated, and that warrant is good for 48 hours. And so that they will take that person into custody, take them to an emergency room or a freestanding behavioral health facility. We provide that assessment, and if it is warranted for them to be inpatient, then they're inpatient under that warrant, and we're able to provide treatment for them.
So do they do that once they come on scene? They assess it there, and
Yes.
then they issue a mental health warrant?
Yes. And so that may be their response. If you call and it's one of those situations and they come out and they deem the person is a danger to themselves or others, or they don't feel comfortable leaving them in that state, then they will apt them. They will do a mental health warrant, take them into custody, and transport them directly to a mental health facility, where we will assess them at that point, and then initiate treatment as is appropriate.
Which brings up another question.
Yeah.
2 local cases here And I'll bring up that Lancaster case again, and also one in Plano. And the one in Plano was the young man had been at a shopping mall or shopping center, and somebody smelled weed. He was arrested. He was picked up, taken to the hospital for mental health assessment, and was released. So, I've shared with my colleague over in Collin County, the president over there, and so he subsequently ended up dead at the hands of sheriff's deputies, who, after he was released from the hospital, he was taken to the jail and ended up dead. So, if, and the family's claiming he was mentally, he had mental health issues, and so is the family in Lancaster. But in both those cases, those young men were taken to the hospital, evaluated, and then released back to police custody. My thing is, somehow the hospital, the facility, the caregivers there are culpable at some level, I think, unless they see them, evaluate them, and think they're good to go.
Yeah,
What role do these hospitals have?
sure. So I'll speak in generalities.
Sure.
In the situation. Okay. So part of the limitation has to do with what you brought up before is the app process or a mental health warrant. So that 48-hour window that a hospital has to assess, at the end of that 48 hours, there are one of two options. Three. One, to engage the person to sign in voluntarily to continue to stay and receive treatment. Anytime they're willing to do that, that's what we would like to do. So we've got 48 hours to assess and try to engage them in their own treatment so that we can have a voluntary stay, because voluntary stays go better than involuntary stays, right? So that's the best outcome. The next thing that we have to assess when we get to that 48-hour window is there enough to petition a judge for an order of protective custody that would extend the involuntary treatment for a longer period of time. The criteria to get an OPC is a higher bar. And oftentimes judges will not grant that on someone who is not sick enough, in their opinion, to take away their rights. This is Texas. That's the conversation. To take away their rights for an extended period of time. You've had them for 48 hours. That's not enough. We're going to release them. We have to release them if the judge does not grant the order of protective custody. And so part of what we're doing in that 48 hours is doing as deep an assessment as we can. If we see that this person we feel needs longer treatment, we want to make the best argument to the judge that we can for continued treatment. And sometimes that works and sometimes it doesn't. But at that point, we have to release that person back. Now, the other opportunity we have is in the discharge plan. So if we know we have to release this person, then it's really incumbent upon us as healthcare providers to try and put in place the best discharge plan that we can, that would hopefully keep them safe in the community and connect them to the next level of care. And so in that process, we tend to try to engage family members if there's family, and obviously the community resources that we know of to try to connect them with those, which includes sometimes calling and making the appointment on their behalf with them sitting there in front of us, right? So that's kind of that space in which it's not necessarily we just think, hey, they're good to go after 48. There's quite a few legal steps in there, some of which we can influence and others that have to do with the judge's willingness to act upon the advice of the physician who's requesting the order of protective custody. Does that answer your question there? There is a sense of responsibility. I'll just tell you that. You use the word culpability. There is a sense of professional and moral responsibility for those of us in this profession. And I'm speaking generalities, but to ensure that we are keeping the public safe and that the person in front of us is not going to experience a bad outcome when they leave. And so I can say here and other places I've worked, there's a lot of effort that generally goes into going like, what option do we have? What do we need to do to try to keep this person safe? Can I call a family member and inquire, are there guns in the home? I need you to lock them up. Do we need to call CPS to do a follow-up? Do I call law enforcement? There's been times that I've had to let people go. And as soon as they walked out the door, I call law enforcement and ask for a welfare check at their address upon arrival. So it's whatever we can do when certain tools are taken away from us. What can we do to try to extend whatever net of safety we can so that they are able to hopefully continue to treat that issue within community-based resources. So.
And I think, thank you for that. I think there's a question that we missed in the chat, or else I wasn't paying attention to the answer. What is the number one mental health diagnosis you're seeing of late? Did he answer that, Billy?
No, we didn't ask.
Okay. What is the number one mental health diagnosis you're seeing of late in African Americans, and what do you believe are the contributing factors?
In African Americans? So depression is probably always going to be number one. The increase that I'm seeing in this particular moment in time is an increase in anxiety-based disorders. And that's not hard to imagine why that would be the case. But the relationship between anxiety and depression is often a bidirectional one. And so oftentimes it's panic disorders, anxiety that will drive somebody to actually seek treatment. Oftentimes people who are depressed need to be driven by somebody else, right? Because just by nature of depression, they're not trying to get out and go about and seek treatment. Depression kind of closes you in its clutches to where you tend to try to shy away from help and not towards it. Anxiety becomes a driver that people go like, this is so uncomfortable, I've got to go get some help. And so I do see an increase in anxiety with African American clients coming in. And again, that has to do with just societal factors. It's been a rough year. It's been a rough year to be Black and brown. And so there's lots of things that are built up. I was talking with someone the other day about grief and how bizarre this year has been when it comes to normal grief and loss rituals, right? We've never seen a time in recent memory where so many people have died alone without family members and not been able to attend funerals. They're doing funerals like this, right, via Zoom. And that's difficult for the grief process. And so we have a lot of people experiencing guilt that they were not able to be there for their loved one's last breath. And so I think part of the reopening and everything like that, there's a lot of individuals carrying a lot of weight and not knowing, how do I grieve? What do I do with this? You know, Mother's Day was Sunday. And I thought a lot about the families for whom that day is the first one without mom. And so there's a lot of it, a lot of residual effect of what we've been through. And that's why I think it's important for each one of us to reach out and connect with someone, to be intrusive, to check in on our brothers and sisters and don't assume they're good. Don't assume they're all right. Don't assume because the loss they suffered was already 8 months ago that they're doing better, right? I'm concerned that this is a grief delayed, and a grief delayed is not a grief that is resolving. it's just delayed and it's going to come out. So we're in an unusual time, but these are the times where being a loving people is probably the best antidote for the pain and loneliness people are feeling right now.
If I could, that kind of steps into something. If I could get your commentary on a commentary, I was listening to Roland Martin, and I can't remember the person who had said they had asked him kind of the same question as Elisa about what do you do, and they made the statement that you need to avoid the crisis situation, and the way you do that is by having a treatment team.
Mm-hmm.
And so as things are going along, you have to have somebody in your treatment team, whether it's a social worker you can call, whoever it is that you can call, that can help the person cope with the situation, and that somebody in the family needs to maybe even get training on coping mechanisms. So,
Right.
because I say the Black families, we get to that anxiety level real high. If somebody can just develop coping mechanisms to help the family slow down and calm things down so that it doesn't get to that level.
Right.
That was very important. I thought that was kind of deep.
No, very, very true. And that's where I think the mental health first aid is that equipping that you're talking about in terms of going like to know what to do. There's not enough of us to go around for every crisis. And so we have to have lay people who care about them, who are the closest person to the individual, that have an enhanced skill set to be able to deal with these before they reach, 100. So yeah, I completely agree with that perspective. And hopefully we can get mental health first aid into our churches and into our groups and be able to train more of our community to be able to respond.
Yep, we need it.
Yes, I do like that mental health first aid and trying to get more people involved in that. You don't have to have a degree to do that. So it is definitely something that I think that our community could benefit from. And I really like the loving intrusiveness, being intrusive but loving. I do like that because we do have to check on each other.
Right.
And if we don't check on each other, who's going to check on us?
Going to.
I know that it's getting late, Dr. Jones. I did want to just ask you your thoughts on any of the laws right now that are up for attention in the Senate laws regarding mental health. And does anything come to mind?
There's so many areas that Texas needs to do better. And I would encourage those who are passionate about a certain gap in terms of mental health in our community to make contact with Austin to figure out what bills. Mr. Wilson, you talked about the school system, and he's personally familiar with some of the gaps there. So I would suggest if you see a gap, become involved at a legislative level. Find out which bills are addressing that. There are groups in your community that work, that actually go down and lobby. I know a lot of social work colleagues that head down to Austin when it's time to talk about a certain bill and testify. So I do feel good about the gaps that exist. There are bills being written and bills that are under discussion that are addressing those, but they need more advocates. So if you have a passion for a gap, connect with at a legislative level and let's make some big change, right? Let's make some changes that can impact more than just our particular community. I think you're on mute.
Yeah, Lacey, you're muted.
I'm sorry, I'm just talking away. Thank you so much, Dr. Jones, for your time and willing to talk to us tonight. This is a topic that, like I said earlier, we can talk on and on about. And it's sad that our community is being affected more than any other community. But we have to continue to have these kind of conversations so that we can help our community. If you can give us your contact information, we won't bother you too much, but you got a lot of information that you could help, and we can reach out to you in other ways in the future, if that's okay.
Sure, yes. And I put my cell phone number there in the chat. And again, I'm at Arlington Memorial Hospital
Okay.
here off of Cooper and Randall Mill. I would be happy to be any of your contact person. If you have somebody in a crisis, I'd be happy to serve as that connector. So I mean that. Feel free to reach out to me, and love to maybe work with you moving forward to see what we can do to help individuals in crisis.
Okay, well, thank you so much, and round of applause. And we really appreciate you coming tonight.
Appreciate the invitation. Thank you so much.
Thank you.
Okay, and I'll be in contact with you because I want to talk to you about a partnership with Arlington Police Department, and I'm sure they'll be open to doing what they're having me to come do, and that's to talk to the recruit classes. And so,
excellent.
Yeah, so I'll be in touch with you to talk about that.
Great, sounds good.
Okay, thank you.
And they put a note in here that they don't see your contact information in the chat.
Okay, I see what happened actually, because I had commented to him earlier. He sent it to me. Yeah, you need to hit everyone.
Sorry.
And so for everyone that's on the call next month, the health committee will also be responsible for the meeting, and we will be talking about the affordable care. So it's not too late to get on the Obamacare affordable care for those of you that are not covered with insurance. Madam President, I toss it back to you. Thank you.
Okay, thank you, Madam Chair. Thank you to you and Dr. Barbara Odom Wesley for putting this together, and next month's meeting as well. We all know people who are not insured, so that's going to be a good meeting to attend as well. Not only has enrollment been extended, but they've increased the subsidies. So people who aren't insured need to come to this meeting, and you guys need to invite them. If there are any community concerns that we're missing that we might not know about? Hearing none, because we hear a lot. Hearing none is good at this moment. I will go ahead and adjourn the meeting at 8:28. Thank you all. We'll see you next month.
Good night, everybody. Have a good night.